Welcome to our workshop, Using ApoE as a Key, Unlocking the Risk-Benefit Conundrum of Amyloid-Targeted Therapy in Alzheimer's Disease. I'm Dr. Sharon Cohen, one of your panelists, and I'm delighted to welcome Dr. Cohen Musiek. Thanks for joining us, Eric.
Hi, Sharon.
Great to have you here. And thank you also to PeerView for providing this session and to Eli Lilly for providing the educational grant. And then look for any follow-up polling questions that pop up during the presentation. Submit your questions into the chat and we'll answer them during the presentation. You can view the slides and practice aids now and download them after the event at peerview.com 2024 ApoE. Our goals for today's workshop are fourfold. We want to improve your ability, number one, to explain the clinical significance of ApoE status in assessing risk for Alzheimer's disease and risk for experience ARIA in patients receiving amyloid-targeted therapies. We also want to help you be able to select appropriate patients for ApoE testing and to be able to educate patients and care partners about the rationale for ApoE testing and the interpretation of the genetic test results. Finally, we want to help you be able to implement shared decision-making when tailoring Alzheimer's disease treatment plans according to the benefits and risks of treatment, as well as the patient and care partner goals, values, and preferences. So let's begin. I'm a behavioral neurologist situated in Toronto, Canada. And what I'd like to start with is the fact that ApoE4 is a gene that codes for the apolipoprotein E, or ApoE lipoprotein, which functions primarily in cholesterol transport, but also has actions on metabolism, inflammation, and microglial activation. ApoE is a normal gene, and the apolipoprotein comes in three isoforms. These are not mutations, they're all normal: ApoE2, ApoE3, and ApoE4. So since we inherit an ApoE allele from each parent, we end up with 2 copies of ApoE, and there are 6 possible combinations. And what we see on this slide is the different isoforms of ApoE have different actions or relative actions with relationship to things like glucose metabolism, cholesterol transport, but particularly for Alzheimer's disease, clearance of A beta, influencing the rate of hyperphosphorylation of tau, and synaptic deficits as well. They contribute to that, and mitochondrial function. So which ApoE alleles you inherit are important in a disease like Alzheimer's disease. In the normal Caucasian population, about 25% of individuals will have an ApoE4 allele. But in an Alzheimer's population, that will go up to 2/3 of the population. About 66, close to 70% of individuals will have at least 1 copy of ApoE4. Similarly, in the general population, ApoE44, 2 copies of E4, is quite rare, maybe 2%, but in an Alzheimer's population, about 15%. And you see on the table on the left the relative risk or the odds ratio for developing Alzheimer's disease based on your ApoE genotype, with ApoE2 being somewhat protective, ApoE3 being neutral as far as development of Alzheimer's disease. It neither facilitates nor protects, so you get this odds ratio of 1. And then when you get to the ApoE4 heterozygote state, 1 copy of ApoE4, you go up to around 3, or a little bit over a 3-fold increased risk over the general population. And then look at ApoE4 homozygotes, about 15% greater risk. So substantial when you're an E4 homozygote. If you look at the table on the right, what you see here is not only, again, this idea that the ApoE4 carrier status increases your risk of Alzheimer's disease, but it also has impact on the age of onset of symptoms, with ApoE4 homozygotes developing Alzheimer's symptoms about 10 years earlier than the general population of sporadic AD, and the ApoE4 heterozygotes about 5 years earlier. It's worth noting that there is a difference in how ApoE genotypes act considering race and ethnicity. And the greatest risk of the ApoE4 allele with respect to Alzheimer's disease is in East Asian and non-Hispanic white populations. And the greatest protective value of the ApoE2 allele is actually in the Caucasian population. When we look at non-Hispanic Blacks and Hispanics, we see some impact of the ApoE4 allele, but not as strong in terms of conferring risk for Alzheimer's disease. Let's talk about the risk of ARIA in the era of amyloid-targeted therapies and how it relates to ApoE genotype. Anti-amyloid therapies or amyloid-targeted therapies first came into the forefront in June 2021 when the FDA granted accelerated pathway approval to aducanumab. Aducanumab is no longer being manufactured. However, in January 2023, lecanemab received accelerated pathway approval for early AD, and then in July 2023, it received full traditional FDA approval for early AD. And just a couple of months ago, July 2024, donanemab received full traditional FDA approval for the treatment of early AD. So we now have two antibodies targeting A-beta intended to treat early AD. So how do these antibodies work? Well, it's important to note that each antibody is a little bit different. With lecanemab, we have preferential binding to soluble A-beta protofibrils and oligomers. We have some binding to plaque. With donanemab, we have very specific binding to plaque-bound amyloid. When the antibodies are introduced into the brain, they're given by intravenous infusion, they get into the brain, they bind their respective species of amyloid, and then they attract microglia, and the process of phagocytosis begins and clearance of A-beta and the antibody antigen complex. ARIA is a radiographic finding by and large. It stands for amyloid-related imaging abnormality. It occurs spontaneously in Alzheimer's disease without any antibody treatment. However, the prevalence of ARIA is more common when there is anti-amyloid monoclonal antibody treatment. There are two types of ARIA. ARIA-E, which stands for ARIA with edema or effusion, and this is representing some inflammation and fluid exudation into the brain parenchyma. You see an image of this on MRI of moderate severity ARIA-E in the MRI imaging. And then ARIA-H, which really represents, for the most part, spots of bleeding, microbleeds, generally asymptomatic. Occasionally, there's bleeding on the surface of the sulcus, and this is superficial siderosis, and rarely macrohemorrhage. Important to note that ARIA radiographically is generally mild to moderate and asymptomatic and self-limiting. So most ARIA, radiographic ARIA, will resolve within a few months. If there are symptoms, they will resolve often faster than the radiologic picture resolves. However, ARIA can rarely be severe, serious, can lead to seizures, disability, even death, so it needs to be monitored for and managed. If we look at some specific data from the phase 3 lecanemab, and subsequently we'll look at the donanemab trial, what you see here on this slide are rates of ARIA-E, and overall, the rate of ARIA-E in the phase 3 lecanemab trial was about 12.5%, and the symptomatic rate was about 2.8%. So the majority asymptomatic. But here on this table, what you see is the breakdown by ApoE4 genotype, non-carrier, heterozygote, homozygote. And if you look in the third numeric column, the lecanemab column, you see that you're going from 5.2% 5.5, 5.5% in the non-carrier of ARIA-E to about 11% with one copy of ApoE4, up to 32.6% ARIA-E when you have the ApoE4 homozygote state. And similarly with ARIA-E, as far as symptomatic rates, they're quite low, but nonetheless, with the ApoE4 homozygotes, you have a 9.2% risk of symptomatic ARIA, whereas ARIA-E was symptomatic in 1.4 of the non-carriers and 1.7, pretty similar in the heterozygotes. And finally, if we look at recurrent ARIA, and ARIA often happens just once in any given patient, doesn't tend to recur. However, there is a greater risk of recurrence in the ApoE4 homozygotes. About 14% will have recurrence compared with 0.4 in the non-carriers and 1.5 in the heterozygotes. What we were talking about was ARIA-E. When we look at ARIA-H, if you look at the last column, again, you will see an increase in ARIA-H rates depending on genotype. And very similar between the non-carrier and heterozygotes. The heterozygote E4 carriers have a little bit higher rate, from 11.5, they go up to 13.8, but 38.3% ApoE4 homozygote rate for ARIA-H. If we look at isolated ARIA-H, this is ARIA-H without concomitant ARIA-E, we see fairly similar rates across the board, and we think it is the combination of ARIA-H and ARIA-E that tends to be symptomatic. Most isolated ARIA-H is not symptomatic. Let's turn to donanemab now. And what you'll see is a similar trend across the ApoE carrier types. You have greater risk of ARIA, both ARIA-E on this slide and ARIA-H, the greater number of ApoE4 alleles. And if we look in this third column, 15.7% rate of ARIA-E in non-carriers, in ApoE4 non-carriers, going up to 22.8% in heterozygotes and 40.6% in homozygotes. So this is about twice the rate as what we saw in lecanemab, but the same pattern of increase based on ApoE4 carrier status. And then we don't have exactly comparable data. We have rates of serious ARIA-E. In the lecanemab data, we had this listed as symptomatic ARIA-E, which is not exactly comparable, but the pattern is there. You have a little bit greater trend in the ApoE4 homozygotes towards serious ARIA-E. And finally, with ARIA-H and donanemab, you see some of these rates and trends very similar, and I'll just highlight here, rather than going through this whole table, that for ApoE4 homozygotes, 50.3% of radiographic ARIA-H. So quite a high rate for the ApoE4 homozygotes, and about 20%, 18.8% in the non-carriers. But of course, the symptomatic rate, which we don't have listed as such here, is much lower. Let's look at timing of ARIA. For lecanemab, we see the front loading of ARIA, particularly ARIA-E, within the first 6 months of treatment. And after that, very low rates of further ARIA. So we see the higher rates for homozygotes versus heterozygotes versus non-carriers versus placebo. But this is really something that's evident in the beginning, in the first 6 months of treatment. And that's where the MRI monitoring is concentrated for this antibody. So to try and pull this together, patients with Alzheimer's disease do have ARIA spontaneously at low rates, particularly ARIA-E at low rates, but the rates will increase with anti-amyloid monoclonal antibody treatment, and that rate will be antibody dependent. But regardless of antibody, there's this trend that the greater copy number of ApoE4 you have, the higher risk of having ARIA, may tend to be more severe, and you may have more recurrence of ARIA. And so it's important to speak with patients and families about this risk. And if one knows one's genotype, then it makes the risk benefit discussion easier because you can point to exactly what the risks are with each antibody. ApoE4 carriers and homozygotes are not excluded from anti-amyloid monoclonal antibody therapy, and they often feel an urgency of treatment. They are often younger than the overall Alzheimer's population, may still be working, and are very keen on embarking on therapy. So it's important, if they want to go ahead, that they stick to the monitoring and management requirements that are in place for ARIA. And let's go to a polling question now.
Okay, everyone. I'm Eric Musiek. I'm a dementia neurologist here at Washington University in St. Louis. I am a member of our institutional committee on the implementation of anti-amyloid therapies, and our Memory Diagnostic Center has over 200 patients on these therapies. I've developed some experience with these over the past year. I'm going to talk about practical strategies for integrating ApoE testing into the counseling into clinical workflows. So I'd like to discuss the criteria for selecting patients for treatment with amyloid targeting therapies. And these criteria are based on the FDA labels for both lecanemab and donanemab, and are based on the clinical trial criteria for both of those drugs. The important inclusion criteria include a clinical diagnosis of mild cognitive impairment or mild dementia due to AD. So it's important not to treat patients who don't actually have memory loss, so patients with a subjective memory complaint, or patients who are too far progressed and have more than mild dementia due to AD. They must have confirmed amyloid positivity, which is done usually with amyloid PET or with CSF biomarkers, such as a p-tau 181 to a beta 42 ratio. And they should meet certain criteria on cognitive testing. So in general, a range on the many mental status tests between 20 and 30 is what was used. In fact, both trials use slightly different ranges, but at our center, we generally use a cutoff of around 20 to include patients, although this may vary somewhat in patients that have aphasia or other factors that might influence their test. You can also use instruments such as the MoCA instead of the MMSE. Important exclusion criteria that need to be considered is contraindication for an MRI. Patients have to be able to get an MRI from a safety perspective. So patients with pacemakers or claustrophobia or other reasons may be excluded. Patients have to have less than 4 microhemorrhages on their MRI. And things like an area of superficial siderosis, or significant cerebral vascular disease, severe white matter changes on MRI, which is somewhat subjective, more than 2 lacunar infarcts, or a single infarct larger than a centimeter. So evidence of sort of active or pretty severe vascular disease, or cerebral amyloid angiopathy, which portends a bad risk for ARIA. Also, people with unstable medical and psychiatric conditions. Anticoagulation use is not a hard exclusion criteria according to the FDA, but it was included in the appropriate use criteria paper that was recently published. It's important to note that anticoagulation use is not associated with an increased risk of ARIA according to the Clarity AD trial, but some of the bad outcomes, the patients that had these rare, severe outcomes, such as macrohemorrhage, were often on anticoagulants, which has prompted people to be wary of anticoagulation. At our center, we actually still include patients with anticoagulation, and they were included in trials. ApoE4 genotype testing is recommended by all patients, for all patients, both by the FDA and the appropriate use criteria, and is really important for informing discussions with patients about their risk-benefit of treatment, which is something we'll discuss in more detail as we go along. So this is a diagram showing the clinical workflow for assessing a patient for potential treatment with anti-amyloid targeted therapies. And this includes clinical workup, as I mentioned, in which they have a cognitive assessment where one can assess their level of impairment, make sure that they fall within the clinical criteria, and that their syndrome is consistent with Alzheimer's disease. And then an MRI, so they have to meet these MRI criteria that I mentioned before, including less than 4 microhemorrhages. And at that point, if they are still appropriate for treatment, then we move on to biomarker testing. This is usually done either by scheduling a lumbar puncture or a PET scan. If they have evidence of amyloid pathology, they continue on the pathway, and at that point is when we consider ApoE testing. So it's important to understand that ApoE testing here is not being used to understand risk for Alzheimer's disease, but rather it's being used to understand risk for ARIA in patients who are likely to be treated with these drugs. So there's some key components of genetic counseling and education for patients who are going to be receiving ApoE testing to inform their treatment. I think that it's important to understand that in the past, ApoE4 testing was generally used to inform AD risk in patients who either had questionable memory loss or were concerned about their future risk. And because of that, these guidelines that were published in 2011 have really, I think, limited value now when we're using ApoE testing for a completely different use, which is essentially understanding risk of ARIA in patients who we have already diagnosed with Alzheimer's disease and that we are going, therefore, to potentially treat with these drugs. In the past, the guidelines suggested that we should have informed consent, which continues to be the case, a rationale for the genetic test, disclosure of implications for patients' ApoE status, particularly understanding the impact that this can have on their biological children and their understanding of their risk of Alzheimer's disease, or siblings or other members of the family, and the potential negative effect they can have. And that's still a consideration I have to consider. And a review of insurance coverage and cost of testing, which is something that we'll talk about. The idea that we'll talk a bit more about genetic counseling and if that's necessary or required for ApoE testing sort of in this new paradigm. After the test has been completed, counseling should include disclosure of the test results, including a personalized assessment of the benefits and risks. So this is where one can consider the numbers that Sharon told us about in the discussion with the patient about their personal risks and potential benefits from these treatments, and to understand their reaction to these test results and evaluate for potential distress. Usually the patient has already been diagnosed with Alzheimer's disease, so there may be minimal distress in the patient, but this is often focused on family members who may, ultimately find out that they potentially have risk of having an ApoE4 allele. So luckily there's been research done on the psychological impact of revealing ApoE4 test results, as they call the REVEAL studies. And this was done because the original 2011 guidelines suggested the use of genetic counseling whenever these test results are being revealed, and there's simply not enough genetic counselors available in the current world to make this happen in this context. So the REVEAL studies looked at people's reaction, first-degree relatives and patients, to having their ApoE genotype disclosed. And they found no negative impact over 12 months from learning one's ApoE genotype, even among people that had ApoE4, and negative impacts were defined as anxiety, depression, or test-related distress. There was no increase in things like suicidality. These studies also demonstrated some methods for communicating this information to minimize clinically significant distress. And they show that, if a genetic counselor is not required to disclose this information, then it's a really big savings of human resources and time versus traditional genetic counseling. Now, certainly there are times when genetic counseling is, appropriate if patients are particularly concerned. And I think doctors and providers need to be aware of that and discuss these things with the patient before the information is disclosed. Once it's disclosed, you can't go back. So I think that if you have availability of genetic counseling and there's patients that are really concerned about this issue, particularly family members, then it's certainly appropriate to use that. So one of the most important things about genetic testing is this potential for discrimination. This is a concern that patients often have. And I think clinicians need to be aware of the existing laws which can protect patients, but the limits of those protections. And so one of the major laws is called GINA, the Genetic Information Non-Disclosure Act of 2008, and it protects pre-symptomatic individuals at risk for a disease based on their genetic profile against genetic discrimination for health insurance or employment. And so your genetic test cannot be used against you to deny you employment or health insurance. However, GINA does not protect against discrimination for life insurance, disability insurance, or other long-term care insurance. It does not do that. Also, GINA may be of limited relevance to patients who already have been diagnosed with Alzheimer's disease, as our patients likely have because they've already undergone biomarker testing before we initiate ApoE testing, and who are already cognitively impaired. So some of this concern is often more about the family members, if they potentially gain new information about their ApoE status and how that could affect their ability to get life insurance, disability insurance, or long-term care insurance in the future. There are some states that have additional procedures, and more information can be found at the National Conference of State Legislatures. So ApoE4 inheritance is relatively straightforward. Patients who are ApoE homozygote ApoE4 homozygotes have 2 copies of the ApoE4 gene. So, of course, each gene we have 2 copies, one from our mother and one from our father. There's 3 different ApoE genotypes one can have: E3, E2, E3, E4. And if one is a homozygote, then their offspring is guaranteed to have at least 1 copy of ApoE4. And I think that's where this discussion comes sort of difficult. If you have a patient that's there with their child and you disclose that they're ApoE4 homozygote, that means that their child is also finding out that he or she is ApoE4 heterozygote at best. And we actually don't know their genotype, but they will know they'll have at least 1 copy of ApoE4. So that is important to know. That can affect the family member's emotional well-being and potentially their ability to get different kinds of insurance if they disclose that information to their insurer. Obviously, you can refer these patients to a genetic counselor, but I think the best strategy is often to discuss this information beforehand, before the information is revealed, so that those children or siblings may have a chance to make a decision on their own. So the insurance coverage for ApoE testing is a bit of an issue in the United States. It's essentially not covered very well. So it's inconsistent. Commercial insurance generally, in my experience, does not cover ApoE4 testing at this point. In 2021, a study showed that 5 of the major commercial insurers did not cover, and 2 require pre-authorization. Now, I don't know how this is changing yet so far in the face of anti-amyloid therapies. Medicare does not currently have a national coverage policy for ApoE testing, which is odd because Medicare does cover these drugs and all associated tests otherwise, but it's generally not covered at this point. It also doesn't cover genetic counseling. So these are potential expenses that are shouldered by the patient, and you have to consider that when you order this testing. So what tests exist? Well, there are several options. One is an ApoE genotyping test. So usually these are PCR-based tests that looked at your DNA to see which ApoE alleles you have. The most common ones are done on whole blood. These can generally be ordered at most major labs, and they use RFLP or PCR, depending on the test, to determine genotype. So these can be ordered, but there's obviously often expense to the patient. There are ApoE prototype tests. So these prototypes look at the protein themselves, often using mass spectrometry. This can be done in CSF or blood. There's several companies doing this, and it's considered a very accurate way to determine your ApoE prototype, which tells you what your ApoE genotype is. There are also PCR-based cheek swab tests that can be done at home that can be ordered off the internet in a direct-to-consumer manner. and are often less expensive. Some of these cost under $100. It's important to understand that most of these tests are not FDA approved, but most are CLIA certified. So before we move on, perhaps you could all take the follow-up poll question. So now we're going to move on to some patient case discussions that Sharon and I are both going to discuss that will sort of illustrate some of these concepts that we've been discussing. So the first is a patient that we'll call Dominic, a 65-year-old man who's a retired electrical engineer with 18 years of education, who's presenting with progressive memory decline for the past 18 months. He scores a 25 out of 30 on his mini mental status test, so mildly impaired. His care partner, Beth, who's sort of serving as a collateral source, that's his 45-year-old daughter, reports that he's been repeating himself increasingly, forgetting appointments, and had some difficulty managing his finances. He's otherwise independent across all his activities of daily living, including shopping, driving, and taking his own medications, and lives independently. His medical history is significant for hypertension, type 2 diabetes, both controlled with medication. Lab work is essentially unremarkable. He does have a positive family history for dementia. So his parents died in a car accident in their 50s, at which time they were cognitively unimpaired. But two of his sisters, 164 and 167, were recently diagnosed with Alzheimer's disease, and both were ApoE homozygotes. And he received a structural MRI that showed some mild bilateral parietal atrophy, some mild to moderate small vessel disease, no MRI contraindications for anti-amyloid therapies, though he did have 2 microhemorrhages on susceptibility weighted imaging on MRI. And to confirm his diagnosis, he was sent for a lumbar puncture and CSF biomarkers using the Alexis AD-CSF panel, which is a commonly used panel. And he was found to have a AD biomarker, a biomarker profile, which is consistent with Alzheimer's disease pathology. So we had low amyloid beta 42, he had elevated p-tau 181, and his ratio of p-tau 181 to A beta 42, which is the most predictive marker, was elevated, indicating likely amyloid pathology. So this is a patient who has a positive CSF biomarker panel and has a clinical syndrome consistent with mild cognitive impairment. So his diagnosis is mild cognitive impairment due to Alzheimer's disease. After some discussion, he expresses interest in amyloid-targeted therapies, and he's told that he needs to undergo ApoE genotyping to predict his risk of developing ARIA. He is interested in this, wants to get testing, but his daughter, Beth, is very worried about her father having the test because she is scared that this genetic test will reveal that she is also going to get Alzheimer's disease. And so there's some key points to discuss with Dominic and his daughter. First is to explain the rationale for ApoE testing. Why are we doing this? Which we did to some degree. Second is discuss the insurance coverage for the testing so he can understand that there may be out-of-pocket costs related to it. Third is to review the legal protections and limitations, and particularly with his daughter, so she understands this on the front end. And secondly, to provide an explanation of how these tests will impact her. So she needs to understand that if her father is an ApoE4 homozygote, that she therefore should have 1 copy of ApoE4 and could potentially have 2. We won't know that. Or if the father is a heterozygote, there's a 50-50 chance that she is also has 1 copy, at least, although we know nothing about her mother's side. And so, Sharon, maybe you could weigh in on how you would deal with talking to Beth.
Sure. It's such an interesting situation because I believe in a patient's right to know and to access treatment, but I also believe in an individual's right not to know their genetics. And here, if the daughter, is against dad getting ApoE genotyping, then she may be blocking his access. It's not mandatory to know your ApoE genotype to initiate anti-amyloid therapy with monoclonal antibody therapy. However, it does inform the risk benefit discussion. There's more than one way to manage this, but my suggestion would be let the patient decide if he wants ApoE genotyping, and let Beth decide whether or not she wants to learn Dad's results. She can still be his care partner and assist in his journey without actually knowing his ApoE result, and therefore save herself perhaps the anxiety of learning that she may be an ApoE4 carrier. Over time, she may become more interested and less fearful. But I think to start out, you want them both to have the opportunity to do what they feel is right for them. And the monitoring and management of ARIA does not change depending on Dad's genotype. But his interest in proceeding with a monoclonal antibody therapy will be influenced by his risk of ARIA. So it makes sense to me that he would go ahead.
Yeah, I agree. And particularly in this case where he has two sisters that are APOE homozygotes, his chance of being a homozygote is quite high. And I think that information has really important implications for his decision moving forward. Certainly, we're concerned about Beth's worries. I would also maybe talk to Beth about, is knowing going to make her more or less worried? She's already very worried. She already has these family members that have their APOE4 homozygotes. Sometimes the fear of the unknown is worse than the actual revelation of the reality. So discussing that, and certainly she could talk to a genetic counselor or otherwise, or just exclude herself. Now, it can get tricky if a patient has to help their loved one make a decision. Then they're going to have to know the information. And so that's where, in this case, Dominic has pretty mild disease. He can probably make this decision on his own, potentially without her, if she really doesn't want to know the answer. So, but it's a complicated issue, and certainly I think this is a realistic scenario at a patient clinic very much like this about 2 weeks ago. So this can really, really happen.
Yeah, it is interesting, and I don't think we should shy away from it. We should be, direct and accepting of what different people want. Different people want different things, but I also think, as a neurologist, I've learned not to expect any catastrophic reactions. Be supportive of your patients, but people often take ApoE results better than you think they might and better than they think they might. So I like what you had to say, Eric, about maybe the fear of the unknown is worse for her, worrying if she is a E4 carrier, than actually finding out and being able to be proactive and do something about mitigating the risk, whether it's lifestyle strategy or having annual cognitive checkups or whatever it is that might help put her at ease.
And I think you made a really good point that ApoE testing is not required, and it also doesn't change the testing that we do in the monitoring. So Dominic could move forward without it, but I think his decision to do it or not to do it is very much influenced by his ApoE4 homozygosity, if that is indeed what he is.
So I think that, it's important when we're communicating with patients to use plain language, to use examples or analogies that are sensible, and forget the medical jargon. That doesn't usually resonate. I talk about different ApoE genotypes like blue eyes, green eyes, brown eyes. And if you have blue eyes, you might be more at risk for certain eye diseases, but these are all normal eye colors, that kind of analogy. Using visual aids can be very helpful. Sharing or directing patients and family members to educational materials, and there are some that are downloadable with this program that you may find helpful to share with your patients so that they can read up on what they've discussed with you and have a resource. And then I wouldn't, get too far afield in the information that's not essential to patient decision making. Try and keep it fairly focused. Allow patients to ask questions and discuss issues of concern. They may have concerns that we're not thinking about, and it's good for them to vocalize so we don't find out in a surprise manner later. And although most patients accept the news of ApoE genotyping quite well, in my experience, there will be some patients who find this difficult news, and you need to be there to support them. And whether it's referral to a genetic counselor, I, similar to Eric, find the counseling is better in my hands because I'm more accessible and I know the treatment options for this scenario. But you want to be there to support your patient, or, if they have a chance to digest the information, leave the door open for them to call you back if they have more questions. That is often just reassuring enough. Because we are being focused in ApoE testing as a way of informing risk benefit for amyloid targeted therapies, we're not dealing, as Eric already mentioned, with using ApoE in the case of treatment options to inform risk of Alzheimer's. People already have CSF or PET amyloid confirmation, so we can sort of skip over that part fairly readily. You do want to spend some time, though, on discussing the influence of the ApoE4 allele on risk for ARIA. You want to emphasize that any genotype, a patient with any genotype can get ARIA, but they're more likely to if they have one, and even more so 2 copies of ApoE4. And so you need to be able to explain what ARIA is. You need to reassure people that it is mostly a radiologic finding without symptoms, but that symptoms can occur, and these are something that should be reported, and there's a monitoring and management plan for ARIA. And I think you can reassure people that ApoE4 homozygote individuals and heterozygote individuals were included in the pivotal trials that led to approval of both lecanemab and donanemab, and that being an ApoE4 carrier is not a contraindication to these therapies. In terms of how we monitor, what we need to do, as Eric mentioned, is get a baseline MRI at least within the year prior to treatment initiation. And we do that to make sure that there aren't excessive number of microbleeds or recent strokes or hemorrhages or other factors that might make the antibody treatment unsafe. If the baseline MRI is acceptable, the pre-treatment MRI, then we have scheduled MRIs at specific times post-initiation of treatment, and we'll see that in the table below. With lecanemab, it's important to realize not just that the antibody is given as an intravenous infusion every 2 weeks, but with the very first dose, you are at the target dose of 10 milligrams per kilogram, whereas with donanemab, less frequent in intravenous infusions every 4 weeks, more convenient, but you are titrating, so it's going to take you 3 to 4 months to get to the target dose. And ARIA rates increase with increase in dose. So having said that, the monitoring with MRI, the schedule for lecanemab is prior to the 5th, the 7th, and the 14th dose. And with donanemab, there are 4 post-treatment initiation MRIs within the first year, prior to the 2nd, 3rd, 4th, and 7th dose, to take into account the difference in these antibodies and how they're delivered. So while we've said that most ARIA is asymptomatic, when symptoms occur, these are the kinds of things that our patients report, and we need to be vigilant for them, and we need to invite them to report if they develop a new headache, if they have confusion, dizziness, nausea, vomiting. So some of it's non-specific, blurred vision, not necessarily focal findings. Occasionally, you do get focal findings. That would be a more severe ARIA, but usually headache, confusion, maybe some gait disturbance. Seizures would be a significant symptom. I would maybe put that under the severe symptoms. And you can classify ARIA symptoms as mild, moderate, or severe. So polling question now, please go ahead and respond.
Okay, so let's discuss shared decision-making about amyloid-targeted therapies. So shared decision-making is really a critical concept for making these decisions with families, but what is shared decision-making? Well, shared decision-making is informed consent plus informed choice plus more. So informed consent is the basics, discussing the nature of the treatment, the risk, benefits, and alternatives, realistic expectations for the treatment, and answering questions. Informed choice adds a discussion of risks and benefits of alternatives, assessing the patient's understanding of what you've said, and discussing and asking the patient and their care partner to make a choice. Shared decision-making incorporates even more, in which we need to identify the patient's needs, values, preferences, and goals. What is their goal of care? What do they envision for themselves? I think this is really important when discussing anti-amyloid therapies. Discuss the uncertainties of treatment. What do we know? What do we not know? How much experience does one have? And then the realities of the treatment, the cost, the inconvenience, other aspects that's going to impact their life. And it's essentially a two-way discussion between you and the family member and the patient to understand, what decision reflects the best interests of the patient. So what does that look like in real life? Well, first, the expected benefit of the treatment. I think this is a really important point. Patients need to understand that this was not likely to make them better. In fact, it's not going to make them better. They're going to continue to get worse. In fact, the patients in the trial all got worse. So we need to manage that expectation that they're not going to feel better on this therapy, but it's going to slow the progression of the disease. However, that's not something that they may be able to quantify themselves. They may not know if the drug is working, and they have to understand that on the front end. It's very hard to know in an individual patient if the drug is working or not. The risks, obviously we discussed ARIA as a major risk. Infusion reactions, these are very common and can be unpleasant to patients, although they're usually pretty easy to manage. And then to discuss their individual risk profile. And this is based on their ApoE genotype. What does their MRI look like? How many hemorrhage and microhemorrhage do they have at baseline? What other medical comorbidities might they have? Are they anticoagulated? Things like that. So there are a lot of considerations in discussing the risk, and that's a very important part of the equation. I think this other part, the commitment and burden, is maybe just as big for a lot of patients. This is not an easy therapy. These drugs require frequent infusions. You have to live near an infusion center or travel to an infusion center on a regular basis. You have to get MRIs. You potentially may have to get a lot of MRIs if you develop ARIA. There's a lot involved here, and patients need to consider, do they want to take on all that burden in their life or not? And their family members who may be driving them back and forth want to take that on. The cost, it's a major concern. Patients here that have Medicare have 80% of this covered, but there's still 20% left if they have a secondary policy, and there's other costs associated with travel and other things. Obviously, there's various other tests that can go along with this. They have to take a deep look at what their insurance coverage is like and also what kind of financial situation they're in. And then what are the alternatives? Can we get just as much mileage out of an existing oral medication like an acetylcholinesterase inhibitor? My lifestyle modifications. Are there other ways to go forward and get this? And so I think these are all things that require a lot of effort, actually. These discussions can be long and involved, but are really important. And that is sort of what shared decision-making is, this discussion. So we're going to go back actually to Dominic, our 65-year-old man with mild cognitive impairment due to Alzheimer's disease, whose daughter was concerned about his testing. So his genotype is, in fact, ApoE44, as we suspected. And so we have some issues. We have to discuss this with Dominic. What does this mean? How does this genotype impact his risk of ARIA? And is he going to decide to go forward? Obviously, you saw, depending on which therapy he chooses or is available to him, ApoE44 does increase his risk of ARIA. As you may have noticed, it did not seem to increase the risk of macrohemorrhage in the clinical trial, but the risk of symptomatic ARIA goes up significantly in ApoE44 individuals. This is a discussion that needs to be had. Talk with Dominic and his daughter about how to be vigilant for symptoms related to ARIA. As Sharon mentioned, that the actual paradigm for monitoring for ARIA, according to the protocols, does not necessarily change in a patient who's ApoE44, but it's important for these patients to be vigilant for some of the symptoms that Sharon mentioned earlier. I think that we also need to talk to Beth. Obviously Beth was a concern. We put forward a scenario where maybe Beth doesn't want to know this information, which you'd be having this discussion with Dominic alone. However, if Beth wants to be involved in the shared decision-making for Dominic's decision, she will ultimately need to know his ApoE genotype. And in this case, this will indicate that she is at least an ApoE4 homozygote and certainly an ApoE4 carrier. So, we can discuss with Beth what that means. She may wish to seek genetic counseling or some other sort of ApoE testing to see what her genotype actually is. And I think that's a discussion that you would have to unfold. Sharon, I don't know if you have any other suggestions about how to deal with this result in terms of talking to Beth.
No, I think you covered it really well, Eric. I agree with everything you said. You want to be respectful of what this means for Dominic and for Beth if she's involved in this conversation. And I guess the only thing I would add is, it's sometimes helpful up front before you do the ApoE testing to explain what the implications of the different genotypes would mean so you don't wait until they have the test result and then describe it, so that Dominic could decide if this really is important to him in terms of his decision about proceeding with therapy. With two sisters who were homozygote, we know that each parent had at least one copy of ApoE4. So again, we shouldn't be too surprised at this result. He was almost certainly going to be at least a heterozygote, and homozygote not so surprising. So I agree with everything that you covered, and including the point that it takes some time to go over results, and we can't rush people. We want them to feel comfortable with the information, so we have to make the time for it.
I will also say that ApoE4 homozygotes, when it comes to initiating treatment, are the most controversial group. So I think that this is a hard discussion to have with the patient, with Dominic, regardless of Beth's concern about her future. These risks of ARIA are real in patients who are homozygous for ApoE4. I mean, as Sharon mentioned, the approaching 50% the ARIA-H risk with donanemab and high numbers with lecanemab. So, I think it's important to really have a detailed discussion about those risks and benefits and what to expect, so that this patient's not surprised, if one of these MRIs comes back with ARIA. I think it's also important for patients to understand that ARIA in most cases is manageable. We often see pictures of severe ARIA or moderate ARIA and hear about these very unfortunate, few rare cases in which patients had really bad outcomes, macrohemorrhage, even some deaths. But those are unusual cases. And oftentimes, even in ApoE4 homozygotes, if they develop ARIA, it's often mild. Often it just requires us to either hold doses or, in worst case scenarios, stop the medication. Most of the patients, the vast majority, are still asymptomatic. So it can still be managed, but it's something that has to be, very carefully considered at the outset, so the patient has the ability to make a good decision for themselves.
Let's go on to another case, a different scenario. Now we have Rachel, a 77-year-old woman, and she has mild cognitive impairment due to Alzheimer's disease, PET amyloid positive, so confirmed biology, and her clinical staging is MCI. So on the surface, it would seem like she might be a good candidate for anti-amyloid therapy, and she's interested in that. She's being evaluated as to her eligibility. She has a history of hypertension and hypercholesterolemia, controlled on meds. She's on hydrochlorothiazide and atorvastatin. Her pre-treatment MRI, however, is informative. She has mild to moderate bilateral parietal atrophy, so that focal atrophy goes along with Alzheimer's disease. It's not unexpected. She has minimal bifrontal atrophy, fine. Mild bilateral hippocampal atrophy, again, not unexpected in Alzheimer's disease to have hippocampal atrophy. But here's what we're getting into now. Severe small vessel ischemic disease. 3 lacunar infarcts, and I think you heard Eric say, more than 2 is putting her at a higher risk for REM. And she has 1 area of superficial siderosis. So she's somebody now who already has some evidence of small vessel disease, a significant amount of it, and some underlying CAA related to her Alzheimer's disease. ApoE testing was ordered to complete the workup, and she's found to be an ApoE4 homozygote. So lots of questions here. Is this somebody that you would have gone forward, Eric, and obtained the ApoE genotype for the purpose of initiating anti-amyloid therapy, or How comfortable are you given the baseline MRI in treating someone like this?
I'm not particularly comfortable, is what I would say. I think that I might have still gotten the ApoE genotyping, but I think if it had come up E4 in this patient, that would have sort of been the last straw for me. Certainly, superficial siderosis makes me nervous. 3 microhemorrhages. I mean, having microhemorrhages at baseline is a predictor of ARIA and regardless of your ApoE status. So I think that this, and not to mention the fact, not just ARIA risk is a concern here, but her response to the drug is questionable. I think if she has so much vascular disease, that could be a significant vascular contribution, and we don't know sort of how that influences her response. And so to me, like, her risk benefit ratio is already not great, to begin with, even before we know her ApoE status. How do you feel about it?
Yeah, very similarly. I feel it's a shame. MCI, she's at the mild end of the Alzheimer's spectrum, confirmed amyloid pathology. But is this a safe treatment for her? The baseline MRI and the ApoE4 homozygote status worries me that she's at a high risk for ARIA. And yeah, she's got severe white matter disease or moderate to severe, and patients like that were excluded from the pivotal trials. So we were using FASECA scores, but anyway, people with mild and at most moderate white matter disease, not severe ischemic disease. So whether this treatment is going to benefit her or just expose her to more risk of side effects, that I agree with you. That's the conundrum. And while I hate to deny therapy, I'm hoping maybe there's another treatment for her down the road or a clinical trial with disease modifying therapy that doesn't consist of an anti amyloid therapy and doesn't have this ARIA risk.
I mean, I think there's so much that is unknown, about these drugs and these protocols, which are all essentially just based on the clinical trial. And that's the best we have to go on right now. But my guess is that over time, as we collect more clinical data, we'll have more data to drive decision-making like this. A lot of times, as you can see, we're using our best intuition, but there is not necessarily a lot of data to drive these discussions. So, we really need real-world data on ARIA rates to substantiate our decisions. And particularly with two different drugs on the market now, lecanemab and donanemab, which have differing rates of ARIA in their clinical trials, but may not have had exactly identical patient populations. I think we really need to know in the real world, are there different rates of ARIA between these two drugs? Is that going to drive our decision-making at all? I think we really need to know more about ApoE4 and how it interacts with other factors, demographic factors like race and ethnicity, because there seems to be a difference in how different races and ethnic groups respond to having ApoE4, men and women as well. So I think that this is something that we need to study more carefully. And then other types of pathology. So obviously we talked a lot about amyloid today, but tau is extremely important. We're starting to get into an era where we have tau PET in some availability, although it's not widely clinically available at this point. We know that ApoE4 can impact tau pathology, and much like it accelerates amyloid pathology, it seems to accelerate tau pathology and tau-related neurodegeneration. And so to understand how that plays out, and that may figure into our decision-making, and also to sort of do this in a personalized way, where we can apply individual thresholds, have maybe models that incorporate multiple variables, like this last patient we talked about has multiple things going on, to sort of make decision making more accurate for patients rather than just sort of based on intuition. And I think as we collect more data, that will be possible. So the take-home points, ApoE4 increases your risk for ARIA, both ARIA-E and ARIA-H. It increases the risk for symptomatic ARIA-E and ARIA-H, which is more serious, but also still quite rare in a vast minority of patients. The implications for treatment with ATTs, ApoE4 carriers are not contraindicated from treatment. the ApoE4 genotype should prompt discussion about risk benefits. And in fact, it's difficult to have a full risk benefit discussion and have real shared decision making without ApoE4 genotyping information. And that patients, regardless of their ApoE status, if they are getting these drugs, they need to be vigilant for, signs and symptoms that might indicate ARIA. And so, Sharon, I'll leave it up to you. You can have the last word if you have other things to say.
Thank you. I think your summary was great. And in terms of real world